Hello and welcome to peptic ulcer disease. This is module 8, part 4. So let's get started. I know that you guys have this is the fourth part of the lecture, but remember I can only record 15 minutes at a time. So when we talk about peptic ulcer disease, let's look at it. Let's turn to chapter 55 and let's look at page 1107. So peptic ulcer disease occurs when mucosal defense becomes impaired and no longer protect the epithelial from the effects of the acid and pepsid. No longer protect the epithelial from the effects of acid and pepsid. So there's three types. So you have gastric, you have duodenal, and of course we have the stress. So look at gastric ulcers. That's on 1107. So the acid, pepsid, H. pylori infections, they all play a role in gastric ulcer. Now we talked about these earlier in the previous lecture about H. pylori infections. So just look right here. Epithelial injury from the hydrochloric acid when mucosa barrier breaks occurs. So where is this hydrochloric acid coming from? Remember when we read about secretions and what is produced in certain organs? So we talked about our stomach and so forth. Hydrochloric acid. If you don't remember, please read up again. So also gastric ulcers. It's the results from back diffusion of acid or dysfunction of the pyloric sphincter. So bile backs up into the stomach. Bile backs up. Can you imagine? It's like a reflux. It's coming back up. So it's a reflux of bile acid. So that acid that should be going down into our intestines, that help break down, further break down that metabolism, those products of what we're eating, that bile is coming up. So that acid that should not be in our stomach is in our stomach and is causing an ulcer. So this can be toxic, and it can destroy the membranes. So understand that. Duodenal ulcers. So let's switch to the key. So most duodenal ulcers occur in the upper portion of the duodenum. So let's look at each of these. Okay, I don't want to just read each slide off to you. That's not happening, and it won't be helpful. But look at the duodenal ulcers. Also occurs in rapid emptying of the stomach. Look what we're finding in common again. That H. pylori goes everywhere, doesn't it? So we need to make sure that we look at our patients, do a really good assessment, see what's going on with them, what do they have a history of. Okay, so let's keep moving forward. And don't forget to reference anything on your chapter 55. So as you read about stress ulcers, oh my goodness, stress ulcers, I want you to look at the third bullet point here. They must receive IV drug therapy to prevent stress ulcer development. Sometimes they get Pepcid, IV, Protonix, IV. We know that these medications, they do what? They help block the acid. You guys remember, look it up, proton pump inhibitor, okay? So multiple shallow erosions of stomach and of the stomach and occasionally the proximal duodenal. So this is where these stress ulcers, sometimes we feel like being in school, we are developing stress ulcers, but we have to keep moving. Okay, so here are some of the complications. I know this is a very busy slide, but take your time and read it. These are some complications that can go on. And now let's look at our assessment and clinical manifestations. So look at that chart that I have here for you, chart 55-5. It assesses the patient history. So look at your patient history. Talking to your patient, you will obtain a lot of information. Then also do your physical assessment. See, ask, are you having any epigastric tenderness? Or then you assess the stomach, right? For any well, you can't see perforations from the inside, but you can ask for any tenderness. You can look for any discoloration. You can ask if they're having any heartburn or dyspepsia. You can, see if they're nauseated or ask those things. Have you been nauseated? How many episodes of vomiting you've had? So checking orthostatic vital signs, making sure that they're not too dry or the fluid volume in their body is not low. So you're making sure that they're safe. Here are some of the testings that can happen. And here's our little friend that just loved to come along with us, the H. pylori. Okay, so they do this esophageal duodenoscopy also on patients where they actually go down and they look and they go all the way down. Sometimes they'll go down and just look into the esophagus and the stomach, but here they're going to go all the way down and look into the duodenum area also. Here are some treatments. So, of course, we're going to try and eliminate that H. pylori infection. We're going to give them some medications to help with the pain, things that help for healing ulcerations, and try our best with education to prevent the reoccurrence. Okay, here's things that they should avoid. This is all of our education that we'll be giving to our patients. So, here's some management for upper GI bleeding. Look at our management for upper GI bleeding. So I want you guys to remember how you do your GI assessment. What will you assess? What you'll be watching for with GI bleeding. Okay, and what do we do? What do we do as nurses? So going back here, ask yourself those questions. Watch for GI bleeding. What are you going to watch for? How about the coffee ground emesis that we talked about? How about bleeding from the rectum? How about the black tarry stools? Those are all signs and symptoms, right? What do we assess? You're going to look at their lab values, their vital signs, checking orthostatic vital signs. What else? Their H&H, the person as a whole. Are they feeling generalized weakness? You're looking at their color. You're looking at their capillary refill, correct? So, and then we want to make sure that those organs are being perfused. So you're looking at their map also. So don't forget about your vitals and calculating your map. Ooh, dumping syndrome. Now, I want you guys to focus on page 117 regarding dumping syndrome. So remember, excuse me, after 30 minutes, it occurs after 30 minutes. Can you imagine you're eating and then after 30 minutes you have a result from a rapid emptying of food into the small intestines, which shifts fluid to the gut, causing abdominal distension? So here are some of the signs and symptoms that go on with dumping syndrome. Okay, here are some of the signs and symptoms that go on with dumping syndrome, and then here are some of the late ones. If you look at the third one, it talks about things that happen like an hour and a half later to 3 hours after eating. You know, the glucose levels, of course, you know, we eat, the glucose levels are going to rise. The patient's going to get a little dizzy or lightheadedness. Palpitations occur, diaphoresis, they get confused. These are things that happen with dumping syndrome. So dumping syndrome is very serious and they're very uncomfortable for patients. Now, here's our Billroth. So you have a parietal resection of the stomach with anastomies. I do have some videos to show you how they cut from one area to the other, but just know the difference, okay? So it's partial resection of the stomach with anastomies to the duodenum. That's this one, partial resection going to the duodenum. But number two, a Billroth 2, is partial resection of the stomach with anastomosis. Then I said anastomies. I'm sorry. Anastomosis to the jejunum. So here they go. They cut part of the stomach here, but then they detach from here, but they add on, they connect with sutures and so forth, surgical, of course, to the duodenum. Okay, so this is a procedure that is done when patients are having different types of GI issues or problems that can't be solved, but they need to have surgical interventions. So let's talk about some biliary disorders. So we talked about cholelithiasis. What is that when they say cholelithiasis? We're talking about gallstones. Very painful, very painful, okay? They can have an end result of some activities with the liver. But first, let's talk about cholecystitis. So cholecystitis, you find it on chapter 29, is inflammation of the gallbladder. It can be acute and it can be chronic. So you can have gallstones, or it can be without gallstones. Okay, so sometimes they do ultrasounds to figure out what's going on with the cholecystitis, because it isn't inflammations. And then the stones, what happens is how the liver get involved. Those stones, they get trapped in the bile duct. So, and then they have trapped bile, is reabsorbed and becomes a chemical irritant. So the patients, they have some edema, some distension, and then also it could lead to gallbladder ischemia and infection. So these patients are put on antibiotics, fluids, getting labs drawn, CBC, and so forth. So acalculous cholecystitis, A without, is associated with biliary stasis caused by any condition that affects the filling or emptying of the gallbladder. So these patients can become septic. Sepsis can cause a trauma, burns, long term. So these are things that can happen that can cause the acalculous cholecystitis, and also your third bullet point there as well. So what symptoms do you see? So sometimes with the bowel obstructions, patients become jaundice. Jaundice is when the skin gets yellow, the mucous membranes, or even the sclera. The most common jaundice is with chronic diseases, though. But they get that yellow sclera, which is called icterus. Icterus. Okay? So make sure you understand that. So you have some risk factors. So here's some of your risk factors. And moving forward, you have the 4F's for cholecystitis. So not saying that these are the only folks who get cholecystitis, but I guess they've done studies to show, on average, this is who the studies are happening, or the cholecystitis is being related to. But anyone can get cholecystitis. But the 4F's are female, 40, fat, and fertile. Okay, cholecystitis. And what they didn't put, oh, well, they did put fertile, so yes. Cholecystitis testings, like I said earlier, you're going to get the labs, the CBC, you're going to check the AST and the ALT. See, because remember that bile duct. So if the duct is blocked, and that those excess fluids from the liver can't go across, the liver becomes inflamed. So that's why you're checking the AST and ALT. So they normally do an ultrasound also. And then also the non-surgical things are pain management when a stone partially or is totally obstructed bowel. They go on pain medicine. Sometimes it moves, that stone moves. So maybe they're also offered surgical interventions, and sometimes patients opt out of it. So they go on pain medications, and they're told to avoid food, and they're told what possibilities that could happen. Lithotripsy, and then the stents. So here are some of the surgeries that can happen. And then let's talk about our genital urinary symptoms on our next part 5.